Three,
Glomerulonephritis
two,
Fellowship
one.
Program. Advanced training in clinical nephrology focused on the management of patients with primary and secondary glomerular disease. It is structured as 3 modules, 20 credit each. Each module will be delivered over a 16-week period. This glomerular disease fellowship is open to physicians who are completing or having completed general nephrology training. Nephrology fellows, early and mid-career nephrologists are encouraged to apply. The GN student will be actively participating in a busy weekly glomerulonephritis and vasculitis scientific materials through participation in an ongoing program that includes lectures, MCQs, clinical case scenarios, journal clubs, academic webinars. Candidates completing the program will have developed sound principles and sufficient experience to manage all glomerular disorders. All activities and assignments will be monitored in the platform. Weekly qualitative assessment and evaluation will be performed based on engagement and activity in the program. The objectives of this program: we have designed the fellowship to advance the knowledge of trainees in the diagnosis and management of patients with all types of glomerular disease. The program is structured to enable trainees to complement but not substitute the education provided by the certified clinical nephrology training programs. At the end of the program, the participants are expected to submit abstracts to national and international meetings for presentation and to submit a manuscript for publication in a peer-reviewed journal. For registration and more information, visit worldkidneyacademy.org. Glomerulonephritis Fellowship Program. Advanced training in clinical nephrology focused on the management of patients with primary and secondary glomerular disease. It is structured as 3 modules, 20 credit each. Each module will be delivered over a 16-week period. This glomerular disease fellowship is open to physicians who are completing or having completed general nephrology training. Nephrology fellows, early and mid-career nephrologists are encouraged to apply. The GN student will be actively participating in a busy weekly glomerulonephritis and vasculitis scientific materials through participation in an ongoing program that includes lectures, MCQs, clinical case scenarios, journal clubs, academic webinars. Candidates completing the program will have developed sound principles and sufficient experience to manage all glomerular disorders. All activities and assignments will be monitored in the platform. Weekly qualitative assessment and evaluation will be performed based on engagement and activity in the program. The objectives of this program: we have designed the fellowship to advance the knowledge of trainees in the diagnosis and management of patients with all types of glomerular disease. The program is structured to enable trainees to complement but not substitute, the education provided by the certified clinical nephrology training programs. At the end of the program, the participants are expected to submit abstracts to national and international meetings for presentation and to submit a manuscript for publication in a peer-reviewed journal. For registration and more information, visit worldkidneyacademy.org.
Hello, everyone, and welcome to our nephropathology webinar today. We have great panelists and speakers. We have Professor Georgina Piccoli, the chief editor of the Journal of Nephrology, the official journal of the Italian Society of Nephrology. Yeah, Georgina. And we have Nikki Wern, Associate Professor of Nephrology in Cape Town University, South Africa. We have Dr. Brandon Bryce, our guest speaker from South Africa, and Professor Essam Noureddin from Ain Shams University, and Professor Wissam Ismail from Bani Suef University. So great speakers, great panelists today. Here is our agenda. We'll have a brief introduction about our GN fellowship. Then Nikki is going to give some samples of the GN fellowships. Then Brandon will walk us through the basic understanding of the renal pathology. And Professor Georgina is going to moderate his discussion. And Professor Essam Noureddin is going to give his speech about clinical implication of renal pathology. Then Professor Wissam Ismail will handle the discussion with him. So we choose the GN for 1-year fellowship because it's very important field in nephrology, and not all nephrologists understand the basic principle and the importance of the GN. It has devastating consequences if we don't treat it properly and precisely. And there is huge management gap in treatment of several GN pathologies. So there is no consistencies and consensus, especially when it comes to the developing countries. So we need to build up a panel of expertise in this field, especially in the Africa, Asia. It's wholly online fellowship program accredited by the American Association of Continuing Medical Education. It's not based on webinars or one-way education, but rather bi-directional education, when we will offer a lot of MCQs, clinical case scenarios, journal club, critical thinking and appraisal, and you will have evaluation and assessment on weekly basis. So the program is structured as 3 modules, 16 weeks each, and it's real education, and it's dialogue, not a monologue, because we need to try to improve our clinical practice and retain the information we are giving you, and to teach you how to apply this in your clinical practice. All the scientific materials throughout this whole year of online fellowship is released through very smart platform. You will have the freedom to navigate through the scientific contents and complete your tasks and assignments before the end of each week. So it's very important to be on top of your assignments. Here is a sample of the module 1 materials. First mini module will be focusing on the basic principle of glomerulonephritis, approach to GN, nephrotic versus nephritic syndromes, histopathology. Each of these topics will take a week. Then we will have a monthly webinar. The second mini module will be focusing on podocytopathy, including mechanism of glomerular injury, minimal change, FSGS. Then we'll focus on membranous nephropathy, diabetic kidney disease, IgA nephropathy. Module 2 is dedicated for secondary GN. The first week will be also a nephropathology week. Then we'll talk about lupus nephritis, ANCA-associated vasculitis, and other kind of vasculitis. GN post-infectious, GN in pregnancy with onconephrology, amyloidosis, February GN, MBGN, C3 glomerulopathy. And the last module will be focusing on GN in challenging situations like hereditary nephritis, genetic studies, post-transplant GN, TMA, novel and traditional therapeutics, including the novel complement inhibitor, plasma exchange, and the pipeline therapeutics. Upon completion of this program, fellows should be a trainer and mentor instead of mentees and trainees. They should be also experts in the GN field, and they should receive American accredited certificates with a 96 credit hour from the American Association of Continuing Medical Education. So we are graduating about 130 fellows this month, the 2024 batch. So congrats for our fellows. We have fellows from 38 countries. It was very successful years, and we are celebrating their graduation on Friday, December 20. So please, all of you are invited to attend this grand graduation ceremony, and we will have surprises and gifts for you. We'll have a recognition of our best fellows as well. So we are going to share with you the invitation link so you can all attend this fantastic graduation ceremony for our 2024 fellows. The 2025 GN Fellowship Program starts next month, and it will be going for the whole year, start January till December 2025. Application closes by the end of this month, and acceptance of notification will be sent to the accepted fellows on January 15th. There will be an onboarding meeting for our fellows on Wednesday, December 22nd. Then the program starts Monday, January 27, 2025. And here, if you haven't joined yet, if you are interested, or if you have any friends or colleague who might be interested, we extended this promo code today. We'll keep it open for another 4 days. You have the QR code, you can scan it. I'm going also to share with you in the group and in the chat box this promo code EARLY10 if you are interested, or send it to your friends or colleague to get 10% discount. I'm going to stop by here, and I'm going to let Professor Nikki Wern to give you some samples, MCQs and clinical case scenarios from our 2025 GN Fellowship.
Okay, just bear with me for 1 second. Deciding not to open now, but I'll be with you now. There we go. So really welcome everybody to this introductory webinar. I must say I'm very, very privileged. I felt very privileged to be part of this World Kidney Academy program. And I'd really like to share with you a little bit about the format and why we're so supportive of this program. And it's because there's a lot of interaction. There's a lot of different ways that you get the information. And I really feel that because of this and the questions that surround the case with the very detailed answers, a really great learning platform. So I'm going to give you, there's three different, well, there's four actually, 4 different ways that the information is shared. Firstly, that there is a lecture and that has been described. Then there are case scenarios about the particular problem. as well as some MCQs that are directly related to the particular glomerular disease. And then there are choices of journal clubs that we've tried to be very up to date and choose particular journals that are actually very relevant for the now. So I'll just give you an example about how the format goes. So I'm just going to close this down so I can read my screen. So this case scenario, and I have an interest in infection-related GN. So this case scenario discusses Miss SW. She's a 42-year-old woman with a 2-year history of hypertension. She's on hydrochlorothiazide, was recently diagnosed HIV positive. Her CD4 count is 220. She's clinically well. She has no opportunistic infections or any leg edema. And her kidney function was performed and revealed a creatinine of 130, which is clearly elevated, with an eGFR of 45 mils per minute. She's been started on abacavir, lamivudine, and dolutegravir, and she's referred for evaluation to your clinic. Her blood pressure is elevated at 150/75, and a dipstick urinalysis reveals 3+ proteinuria and no hematuria. So after the case scenario, you'd be given questions that would look something like this. So what further tests would be most helpful in the workup of this patient's abnormal kidney function? Would it be an HIV viral load, a urine protein creatinine ratio, a urinary LAM, maybe TB is suspected, microscopy, sensitivities and cultures, or a serum albumin? And I'll just give you a second to think about this, but the correct answer is B, which is the urine protein creatinine ratio. So following the question, there is then a discussion about why the answer is correct and why perhaps the other answers are not correct. So a kidney biopsy is required for definitive diagnosis for HIVAN, but the following features strongly suggest HIVAN, and that includes nephrotic range proteinuria without leg edema, significant proteinuria without hematuria or edema. UPCR at this stage, as we mentioned there, is useful. Blood pressure in HIVAN is normal or low, and that's because this is a salt wasting kind of nephropathy. And this patient has an elevated blood pressure that predates the HIV diagnosis, suggesting perhaps a different cause. The HIV viral load is really not very helpful here. It's often seen in untreated, newly diagnosed HIV, so it's less helpful. And the low CD4 count, she has a CD4 count that's 220, which is lowish. It's common but not definitive for the diagnosis. And we didn't mention this, but large kidney on ultrasound are frequent finding, but they're not reported here in the case scenario. And we really tried to reference the information that surrounds the case scenario. So she then comes back to you in 6 months. She's been put on angiotensin receptor blocker losartan, 50 milligrams daily for her proteinuria and blood control. I'm just going to move the screen because I can't see it. Her creatinine is now 180, so it has elevated, and she has persistent proteinuria with a UPCR now of 0.5 grams per millimole, or 5 grams per 24 hours. She now has that ultrasound that demonstrates large kidneys of 13.5 and right 13.5, left 13.8. They are echogenic, suggesting that there is some chronicity, and you now recommend a kidney biopsy. And below is the biopsy that is performed. So this is a methanamine silver stain, and we try to educate about the different types of pathological, different types of stains that we see for evaluating glomerulonephritis. And here you can see a very abnormal glomeruli and these very dilated tubules. So what is the likely diagnosis given the kidney biopsy picture that we've seen? Is it a crescentic glomerulonephritis? Is it HIV-associated nephropathy, hypertension, diabetic nephropathy, or membranoproliferative GN? And here you can see that the answer is B. And then we discuss perhaps what is the structure depicted in Figure 1 labeled A. And here, this is very much a characteristic feature of HIVAN, which is a microcyst. So the correct answer is D. So what I found very useful for this kind of presentation is that the description goes on to discuss the case a little bit more. And in this, for example, this case, the hallmark features for classic HIVAN include a collapsing glomerulopathy, tubular microcysts, podocyte and parietal cell hyperplasia and hypertrophy, with interstitial infiltrates that are classically plasmacytic in nature. And we try to be very specific about getting very up-to-date information or where possible, some guidelines or definitions from very reputable literature. So the pros and cons of this MCQ. So I've talked to you about the case scenario, and then we try to just sort of get this MCQ structure throughout our teaching and learning experience. And these reinforce all the core topics. They assist with learning through explanations. They're a quick way then to cover the core topics. And in this, during the learning experience, one has a direct line to the supervisor who's responsible for it. So if it was infection-related GN, it would be myself. So we then have another example of the type of questions that are seen, and I'm just going to just go on to say I didn't do the vasculitis associated section, but you might then get a group of questions that are pretty relevant just for example, ANCA vasculitis. For example, what is the mechanism of action of Avacopan, a drug used in ANCA vasculitis, with a list of different mechanisms. And in this case, C5a receptor antagonist is actually the answer. And then following that, there's I'm not going to go through this, but a detailed explanation of the answer. This is a new drug, so it's very important that one understands it. And then the pathophysiology of ANCA-associated vasculitis is described. And then there is more detail about what the proposed mechanism of action of Avacopan is. And then the third way we examine the case is by providing different journals that are associated with the topic. So, for example, I chose this neglected and emerging infections of the kidney, and you get an opportunity to review the literature. And then we provide some questions just to enhance your learning. For example, which of the following flavivirus has been associated with kidney disease and or detected in kidney tissue and urine? Is it Japanese encephalitis virus, tick-borne encephalitis virus, Zika virus, hantavirus, or influenza A virus? And the answer here is C. And then we try to give a rationale for this. For example, there are four flaviviruses have been associated with kidney disease and or the presence of flavivirus in kidney tissue and urine: dengue, yellow fever, Zika virus, and West Nile virus. The Zika virus, therefore, is the choice of the viruses above. So you can see we've taken the information that's actually come from the journal, and we try to enhance your learning by giving directed questioning for this. So on that note, I've given you a little, I'm going to stop share. I've given you a little bit of a tour about what a section would look like. As this is a glomerulonephritis topic, it really is my great pleasure today to introduce Dr. Brendan Price, who I really am very fortunate to work with. He's a distinguished anatomical pathologist who works at the NHLS at Groote Schuur Hospital and the University of Cape Town. He's completed some prestigious training programs, and I must say what is really special about Brendan is a passion for advancing kidney pathology with our younger staff members, and also we have had many webinars that we've been working with Brendan. He also holds a PhD in biochemistry, so we're fortunate to have him on our team. And we look forward to his presentation this evening, which is really an introduction of the basic understanding of nephropathology. So, Brendan, if you want to just load your slide, and we'll really look forward to your presentation.
Great. Thank you very much for those very kind words, Nikki. And yeah, good morning, good afternoon, and good evening to everyone. wherever you may be in the planet at this moment. I just want to just confirm that everyone can see my slides and can hear me.
Looks beautiful.
Great. Okay, so as Professor Wern said, my name is Brendan Price. I'm one of the anatomical pathologists at Groote Schuur Hospital in Cape Town, and I'm a general pathologist, but I am responsible for all the native and allograft kidney biopsies that come through our division. And although I only have 20 minutes, I hope that I can give a really good introduction to um, an approach to glomerular disease, so that it doesn't seem so intimidating to nephrology fellows. So to begin off with, what I like to think about is the five main common indications that we receive biopsies for, and these include nephritic syndrome, nephrotic syndrome, and in some instances we have a nephritic-nephrotic overlap, acute kidney injury. We may have a biopsy for someone who is known to have chronic kidney disease, but has possibly had an acute deterioration in their renal function. And then less commonly, asymptomatic or symptomatic hematuria. So these are the five main kind of clinical scenarios that we get biopsies for. And ideally, when a biopsy is taken at the bedside, either a pathologist or a technologist who's skilled in dissecting microscopy should be there, so that the adequacy of the biopsy can be determined at the bedside. And ideally, once you take a little biopsy and you look at it under dissecting microscope or angulated light, you should be able to see the little glomeruli which are embedded in the cortex, confirming that you're cortical in location, and that you can also take little samples off for electron microscopy for further analysis. This may or may not be possible depending on the workload of the pathologist or the technician, and so it's always a good idea to get some training as a renal fellow or a registrar in being able to do this at the bedside. This, of course, is the best case scenario if we're looking at a kidney that's relatively unscarred. But in cases where patients have chronic kidney disease and there's a fair degree of interstitial fibrosis and tubular atrophy, the glomeruli can be somewhat obscured. For routine biopsies, the general consensus is that we would like to see 10 glomeruli and 2 arteries. But that also depends on what the pathology is, or the pathology that is going on in the kidney. In some pathologies, you can expect almost 100% of glomeruli to be involved. So something like perhaps advanced diabetic glomerulopathy or membranous nephropathy. However, some entities are notoriously focal and segmental, such as FSGS or maybe class 3 lupus. And so the more glomeruli that we see in a biopsy, the greater chance we have in being able to identify the lesions that are causing the clinical scenario. And we need to get a lot of mileage out of our biopsies because, as you'll see in the next couple of slides, we utilize a whole range of different types of histochemical stains and immunohistochemical stains and electron microscopy where it's available to uncover the underlying cause of the GN. And so the more glomeruli and more tissue we have, the better for that. And as you'll go through the fellowship program, you will come and become familiar with all the different special stains that we use. And the hematoxin eosin or H&E stain is the general stain that we all use in pathology, although it's not the greatest stain for kidney pathology, but it gives you an idea of what your glomeruli look like and a basic idea about what your vessels and your tubular interstitium look like. However, when we want to look at the mesangial matrix, or we want to look at very subtle thickening of the glomerular basal membrane, which we may get in early membranous nephropathy or diabetic nephropathy, then we utilize the PAS stain, which is the periodic acid shift stain. We also use a Jones stain or a silver stain or a GMS stain. You may use it, we may use a number of different terms to describe the stain. And this is a special stain that allows us to really look at basement membrane material and the basement membrane itself. And so this is indispensable for identifying the spikes that we see in membranous nephropathy, the double contours we see in membranoproliferative GN, and it also highlights very nicely areas of necrosis and glomerular basement membrane damage that you can see in your necrotizing glomerular nephritides. Then the Masson's trichrome stain, which is here on the bottom right-hand corner, is one that we use to assess for fibrosis. So basically looking for scarring in the kidney, being able to semi-quantitatively assess whether it's mild, moderate, or severe is useful. And in some instances, if you're very lucky, you may be able to pick up thrombi in the case of antiphospholipid syndrome or thrombotic microangiopathy. But sometimes we use different stains in order to identify those. We routinely use Congo red in every single kidney biopsy that we receive as a screening for amyloidosis, but in some laboratories that is not the case. So this is the wish list of every pathologist to get from the referring clinicians, but I understand that depending on where you are based and where the different other laboratory investigations are performed, this may not be readily accessible. So ideally, we'd like to have a good history with the presenting syndrome, one of the 5 presenting symptoms that I showed in my first slide. Any of the patient's comorbidities, which could be very useful because we may have more than one disease process going on at the same time. So, for example, we may have someone who has post-infectious glomerular nephritis and is a diabetic, or someone who has membranous nephropathy and is also hypertensive, in which case we'd be able to see both types of injury. Any forms of drug history and where we are, where we think we are in terms of the progression of the disease. Ideally, we would like to have access to all the critical laboratory findings, either on the electronic record or it being included in the referral form. And if nothing else, the creatinine, UPCR, and the complements are the most critical for us. As I mentioned before, we need to have adequate representation of cortex. So mainly we want cortex because that's where the glomeruli are located. And as I said, it's not a hard and fast rule. In some instances where we have very diffuse disease, we can probably make a diagnosis with far less glomeruli. But in cases where the disease is typically focal and segmental, we would require more glomeruli in order to increase the probability of finding these lesions. The special stains or histochemical stains need to be well performed, and the immunofluorescence or immunohistochemical stains need to be correctly interpreted in the case of immune complex mediated glomerular disease. In some institutions, they may have access to electron microscopy, and we are lucky enough that we do have an electron microscope. However, I believe that a number of diagnoses can be made without an electron microscope, and I'll show you a couple of them as I go forward. And then ideally, we need to use very strict terminology, which are KDIGO terminologies, in order to describe the lesions that are being seen in our report, and to use standardized scoring systems in the kidney biopsy report. So what are some of the causes of glomerular injury? And I like to roughly divide them into immune-mediated causes and non-immune-mediated causes. So when I get the suspicion that something is immune-mediated is when I get a biopsy that's come in with a history of a patient presenting with nephritic or nephrotic syndrome with low complements, and maybe they have got a positive ANA screen, or they are known to have a monoclonal band on serum protein electrophoresis. And in this case, it's useful to think of immune-mediated causes as either being anti-GBM antibodies, where the actual antigen is the type 4 collagen in the basal membrane, whether immune complexes which are circulating in the blood circulation deposit in the glomerulus, and when they deposit there, they can activate the complement cascade. And this can be seen in many different forms of glomerular nephritis. And wherever the deposits end up in the glomerulus is largely a basis of their charge, although some entities show fairly typical or predictable sites of distribution, such as IgA nephropathy being paramesangial or in some cases subendothelial in location. Porcy immune or the anchor vasculitides, and then a monoclonal paraproteinemia, so something like AL amyloidosis or light chain deposition disease. The non-immune-mediated forms of glomerular injury are more sort of systemic diseases which tend to affect the glomerulus, and this can be forms of podocytic damage and the various forms of FSGS, hypertension, diabetes, and then non-light chain amyloidosis. So every component of the glomerulus can become injured. And what we need to understand when you're starting out in glomerular pathology is being able to identify the different cells or the different structures within the glomerulus and understand that the glomerulus only has a limited number of ways of responding to the injury. So once you know what the structure is and how it responds to the injury, it can go a long way in being able to allow you to come to the diagnosis. So pathology is all about pattern recognition and using correct terminology. And as I said before, in glomerular disease, the pattern and the response to injury can give you clues about where the injury is occurring and what the causative etiology is. So some of the sites that become injured are the podocytes, which are located on the outer aspects of the capillary loops in Bowman's space. The podocyte damage is sometimes quite difficult to see on light microscopy, and it's one of the main reasons why we use electron microscopy, because damaged podocytes tend to show very specific characteristics when they become injured. And podocytic damage we can see in a variety of different glomerular diseases. Endothelial cells in membranoproliferative GN, post-infectious GN, and class 3 and class 4 lupus get damaged because immune complexes lodge themselves underneath the endothelial cells and activate the complement system. The mesangial cells, which are in these areas of pink, so this is a PAS-stained glomerulus, and all the little blue nuclei which are sitting in this pink or magenta matrix here are the mesangial cells. And these are the targets for, or the locations of immune complex deposition in IgA nephropathy and class 2 lupus. The capillary loops, which are these little loops that you see here in the end, the glomerular basal membrane, are the targets for Porcy immune GN, which can cause breaks in the glomerular basal membrane and the formation of cellular crescents. And they also show ischemic or wrinkling when you have patients with uncontrolled hypertension. And then finally, the mesangial matrix itself can become replaced or infiltrated by various proteins or protein products. And this is something that we see in case of uncontrolled diabetes or amyloidosis. So what are some of the responses to glomerular injury? So podocytes, when they are injured, result in nephrotic syndrome because the podocytes maintain a correct slit diaphragm, which allows, it contains albumin to remain within the capillary loops and prevents proteinuria. So when they are damaged, the slit diaphragm is perturbed and the patient presents with nephrotic syndrome. And this is something that we see on electron microscopy, which is the microvillus transformation in minimal change disease and FSGS. And in cases of membranous GN, where you've got an immune complex deposition, the basal membrane itself starts to form spikes as a way of trying to wall off or sequester the immune complex deposits to prevent damage to the podocytes. For endothelial cells, when they are damaged, they tend to present with nephritic syndrome and they become swollen, or what they call hypercellularity. And we can see this in membranoproliferative and post-infectious GN. And if that occurs for long enough, in the case of MPGN, you can form a second basal membrane. Again, a way that the glomerulus tries to wall off or sequester the immune complex deposits to prevent any further damage to the glomerulus. In terms of mesangial cells, they can become hypercellular, and we see this in IgA and class 2 lupus, and in some forms of C3 glomerulopathy. And the capillary loops can either be wrinkled with hypertension, I'll show you a picture of that, or you may get actual breaks in the glomerular basal membrane due to the enzymes that are released during neutrophilic inflammation. And when you get a break in the basal membrane, plasma protein pours into Bowman space, and that incites the formation of crescents from the parietal epithelium. And the mesangial matrix itself will expand, and we use different methods to identify what those components are. And in general, patients will present with nephrotic syndrome. So this is just an example of some of the patterns of response to injury that the glomerulus can form. So in light microscopy, you can have what looks like a fairly normal glomerulus, and I put that in speech marks, because in the case of this, if you see a normal looking glomerulus and you know that the patient has come in with nephrotic syndrome and all the complements are within normal range, you can immediately think of a podocytic damage or podocytopathy and would go immediately to electron microscopy. Podocytic damage is unfortunately not visible on light microscopy in this case. The second of intercapillary hypercellularity, this is a common response pattern or response injury pattern that we see in infection-related GN or in early proliferative phases of membranoproliferative GN. And this is where the capillaries have all become swollen shut because the endothelial cells have become damaged, and they are damaged and swollen because there are immune complexes underneath them, and those immune complexes are activating the complement cascade, causing leukocytes to infiltrate into the glomerulus and release reactive oxygen species. We have double contour formation, which we get in long-standing subendothelial deposits. So in the case of membranoproliferative disease, and this is a Jones stain, a silver stain, which helps us identify the second basement membrane. Then this is also a Jones stain at high magnification, showing these little brown spikes, which is the response of the basement membrane to subepithelial deposits. So deposits which are underneath the podocyte. These spikes are being grown in order to try and cover up these immune complexes and to prevent any podocytic damage. This also is a Jones stain, and this shows the formation of a cellular crescent. And cellular crescents can occur in a number of different types of immune-mediated disease, ranging from Goodpasture syndrome to lupus to porcine glomerulonephritis. And what we like to do is age the crescents to say whether they are cellular, fibrocellular, or fibrous crescents, because the older the crescents become and the more scarred they become, the less likely are to reverse the damage and retain glomerular function. This is also a Jones stain showing the expansion of the mesangial areas by a protein or a substance which is not silver positive, and this is characteristically amyloidosis. And this is another pattern that we see. And if we see a silver negative mesangial matrix, this is when we would do a Congo red stain and birefringence. And then another pattern we have here is the segmental scar, which we can see in focal segmental glomerular sclerosis. Again, this is a Jones stain, but any pathological lesion that causes damage to the glomerulus can cause a focal and segmental scar. This is what a glomerulus looks like in someone with uncontrolled hypertension. You can see how wrinkled and completely irregular the basal membrane contours are. And this has got to do with ischemia. And this is what we see typically in uncontrolled hypertension. And then this is a globally sclerosed glomerulus. This is the final common endpoint for any glomerulus that has sustained injury that hasn't been addressed or hasn't been treated. Unfortunately, it's very difficult to say what the exact etiological agent was that caused glomerular sclerosis once you get to this stage. So once we have had a look at the pattern, and if we think that we're dealing with immune complex mediated form of injury, the next thing to do is to try and identify what immunoglobulins or complement factors are present in the glomerulus and where are they, what is their location. And depending on which laboratory you're in, you may either have access to bright field immunoperoxidase staining, which is what I have in my division. This uses fixed tissue. It gives a very nice permanent storage. You can store it with your normal slides. You can take photographs with it on your iPhone. However, it is less sensitive than immunofluorescence, and sometimes we can battle with high background staining. However, in the rest of the world, especially in Europe and America, unfixed immunofluorescence is used. This requires a separate piece of renal tissue that is only processed for immunofluorescence. And this has the advantage of being very sensitive with low background staining. However, you need to have access to a fluorescent microscope and ideally a digital form of storage of your images. So these are the two main modalities that we use. And so on the left-hand side, this is an example of the subepithelial hump-like deposits you see in post-infectious glomerulonephritis or infection-related glomerulonephritis. And the antibody here was towards complement 3. So now there are many different patterns of immune deposition that you will learn about, and each form of the patterns of response to injury will give different patterns of immune complex deposition. So the pattern that you see under light microscopy, such as, for example, in this endocapillary hypercellularity example, should correspond to this linear or curved or comma-shaped deposits that would indicate that the immune complexes are below the endothelial cells. For someone who's presenting with Goodpasture syndrome, you'd expect to see a very linear staining pattern of anti-GBM antibodies because the antigen in this case is the actual glomerular basement membrane itself. In the case of post-infectious GN, you'd want to see really large and small deposits of immune complexes, which would then say to you that we definitely have subepithelial large hump-like deposits. So in most cases, you would stain for various members of the IgG or the immunoglobulin subclasses, such as IgA, IgG, and IgM. IgA mainly for IgA nephropathy, IgG for membranoproliferative and lupus and anti-GBM. IgM you would see in cryoglobulonemic GN, C3 and C3GN, but you can have various combinations of these staining, and in lupus you typically have your full house staining. And one thing to just mention here is that in lupus you can see many different patterns happening depending on what class you have. Then onto electron microscopy. This is something that we use to look at very specific perturbations that occur during glomerular disease. And one of the main reasons we look at is podocyte morphology. And this is a cross-section of the podocyte foot process. And two foot processes are side by side. And here is your slit diaphragm that is maintaining a barrier to albumin being released into the urinary space. Then you have your basal membrane and you have your endothelial cells. And remember that they are fenestrated. They are not closely opposed to each other. There are little spaces in between. And these are spaces where your immune complexes can actually get underneath your endothelial cells. And that's what the basis of subendothelial deposits, how that arises. So we look at the endothelial cell, usually not so much, but what we really want to do is identify electron-dense deposits. And this should really be confirmation of what you get from your immunoperoxidase or immunofluorescence. In most cases, that would just be confirmatory. But in some instances, when you're looking at structured deposits, such as immunotactoid GN or cryoglobulonemic GN, that structure to the deposits can be something that you only see on electron microscopy. And then in some instances, when we're worried about diseases such as SYN-GBM disease or Alport syndrome, the electron microscope is really indispensable for looking at any abnormalities in the GBM structure itself. And so I've just given a few examples of what we can see on electron microscopy. And in the cases of podocytopathies, we'll see foot process effacement, which means that those little very orderly foot processes that you see in a normal GBM become fused, and the podocytes become flattened as a result of podocytic injury. And this, together with microvillus transformation, would be helpful in us being able to confirm that we're dealing with minimal change disease or FSGS. In terms of post-infectious glomerulonephritis or infection-related glomerulonephritis, we have these very large electron-dense subepithelial hump-like deposits. Now, once you get to electron microscopy, this should only be confirmatory, because up until now, you would have been presented with a clinical scenario of nephritic syndrome. You'd know that the patient has a low C3 or maybe a raised ASOT or anti-DNase B titer. You would have done immunofluorescence, which have shown you immune complexes, usually in a very granular fashion. So electron microscopy here would just be confirmatory. But in areas where electron microscopy really comes into its own is being able to identify structured deposits. And in this case of amyloid, we're able to see the fibrils, and at very high magnifications, we can measure the diameter of the fibrils, which will then be able to allow us to very correctly identify the nature of the deposit. So I understand that, most people may not have an electron microscope, but I don't think an electron microscope is absolutely essential in most diagnostic fields, because if you have a very good silver stain with double contours, that is basically telling you exactly what you would see as a double contour in electron microscopy. If you have a very good silver stain being done, these little sparks that you're seeing here of brown are exactly the same, the sparks growing up over the electron-dense deposits that you would see under electron microscopy. However, I'm not saying that the electron microscope should be taken away with completely, but for most instances, you can probably, with very good histochemical stains, get an idea about what's going on, and for select cases, try and send out for electron microscopy. So the more information I receive, the less differential diagnoses I have prior to actually putting down my slide on the microscope. And I must say, working with Nikki and her team is an absolute privilege, because they provide me with a lot of information, and quite often before I even put the slide down, I have an idea what I'm dealing with. And so here I've just given a theoretical situation where a case has only been labeled as nephrotic syndrome. And I know some of my colleagues in private practice sometimes get this, where they can't access the lab results and they just get something like nephrotic syndrome. And when you get that, my differential diagnosis is quite long, ranging from a podocytopathy to amyloidosis to membranous nephropathy. If I now know that the complements are normal, I can probably do away with membranous as a differential. If I know that the patient has a normal HbA1c, I can probably rule out diabetes as being a cause of nephrotic syndrome. If I now get told, especially in our patient population, that the patient has previously had TB and there are a lot of apical cavities, this is something where I would really be suspicious for amyloidosis, such as serum amyloid A amyloidosis. And this is a picture of a glomerulus which is stained with Congo red, showing Congo red positive material. And when you polarize the light, you get this birefringence. And in the textbooks, I always talk about apple green birefringence, but in practice, they can range anything from green to yellow. And so if you really wanted to nail the diagnosis, you could do electron microscopy, but this is diagnostic in and of itself. Electron microscopy is not absolutely necessary in this case. So the road to diagnosis is complex and requires the interaction of a number of different areas in order to be accurate and in order to be the most informative and of most use to clinicians. First of all, we have a good clinical history and examination, which are our 5 indications. We need to understand what the pattern of injury is. From the pattern of injury and the laboratory investigations, we can usually predict what the immunohistochemical and special stains are going to be. And then in some instances, we require electron microscopy in order to really tease out entities that may be a little bit less common. So at every point in the whole multi-step process, nothing should be a surprise to you or the clinicians. Everything should be confirming itself, and everything should make sense. So in some instances where you don't have any clinical history and you don't have access to any laboratory results, which is very unfortunate, these next 2 slides are a suggested algorithm that you can use in order to still come to the right diagnosis. And this is taken from Silver's Diagnostic Renal Pathology. And you can see when you don't have any information, your differential diagnoses for every type of pattern or response injury that you're seeing is quite large. So ideally, have as much information before you put down your slide onto the microscope to help you get that. All right. Thank you very much for your attention.
Thank you so much, Brendan. That was such an excellent overview. I think, yeah, very hard to do the topic justice in a small amount of time. So well done for that. I think we are a little bit behind schedule. So I think we had decided we'll let the next speaker do their presentation, and then we can have a discussion following that, so that we ensure that everybody has can have an adequate time to do their presentation, if that's okay. So.
Well, thank you, Nikki. Yeah, I think that's okay, and I'm very happy to introduce my old friend, Professor Essam Nuruddin, a very eminent and experienced nephrologist from Ain Shams University, who has a very special interest in renal pathology, and he's going to talk to us about the clinical implications of renal pathology. And looking forward. Essam, please.
Thank you very much, my dear friend, Dr. Wissam. Greetings to all my friends and colleagues. My role today is from a nephrology perspective. I'm going to speak about the clinical implications of nephropathology in the sector of glomerulonephritis, whether in the native kidney, which is the main, and also including the renal allograft GEN. I will go directly to the main clinical implications for nephropathology in GN, and these are the main 5 clinical implications. Of course, it will help to decide the diagnosis, the prognosis, the disease progression, guiding therapy for some types of glomerulonephritis, as we are going to see, as well as for showing response to treatment, or in cases of refractory glomerulonephritis to the standard therapy. The implication here is very important to show us what is going on. So I will discuss every item of this in the coming short time. The first item is the diagnosis. Of course, the interplay of the 3 types of microscope, the light, immuno, and the electron microscope. In the majority of cases, we can give a clear diagnosis of GN, and sometimes differentiating between whether it is a primary or secondary form, like in FSGS and in membranous nephropathy. but also the pathology actually will help us when no other ways of diagnosis can help. For example, this disease, the IgA nephropathy or Berger disease, in French it is maladie de Berger, after the Jean Berger, the French pathologist. The only way to diagnose IgA nephropathy is by immune microscopy, demonstrating the positivity of the immune antibody stain to IgA in the mesangial lesions, whether as the only or the predominant or the co-dominant abnormality. You cannot diagnose IgA nephropathy without pathology, without immune microscopy in particular. And all of us know that IgA nephropathy is considered to be the most prevalent worldwide primary GN. Another condition in which the pathology for the glomerulonephritis, it is very essential and is very important and it is mandatory, and without this we cannot diagnose what is going on, is one of the types of rapid progressive glomerulonephritis or crescent glomerulonephritis, which is type 5. Type 5 is the ANCA negative. In this scenario, the serology is negative, including anti-proteinase 3 and anti-MBO, or including even the ANCA testing for the perinuclear or for the cytoplasmic. It is negative. And the only way in this condition is to do a pathology showing the combination of crescent glomerulonephritis of different age of evolution, as you see, cellular, fibrocellular, and fibrous crescent, together with fibrinoid necrosis. And the most important thing is to have this nearly negative immune fluorescence pattern. Without this combination of light and the immune microscopy, we cannot diagnose this ANCA-associated glomerulonephritis of the ANCA negative type. It is to be noted that the ANCA negative immune crescent glomerulonephritis is associated with fewer constitutional and extrarenal manifestation. But the main problem is in the glomerular involvement. It is a severe degree of involvement, and it has a poorer prognosis as compared to the ANCA positive, ANCA-associated variety. Also, in some systemic diseases like systemic lupus erythematosus, and it is to be noted that this disease is quite prevalent in my country, in Egypt. It is not as written in the textbooks. It is a very rare collagen vascular disease. It is prevalent in my country. So there are certain characteristic features in the different microscopes. When seen by the pathologist actually help us and they tell, please think about lupus nephritis. Like in the light microscope, the finding of this rare situation, but it is considered the diagnostic or pathognomonic hematoxylin bodies. It is an apoptotic nuclei, the presence of wire loop lesions. In the electron microscope, finding all levels deposits together with fingerprint-like deposits and viral-like particles or tubulo-reticular inclusions. The presence of these highly suggests the possibility of lupus, and in immunofluorescence, all classes of immunoglobulin and complement in what is called the full house pattern. The presence of any of these or the presence of a combination of these findings in different microscope actually raises the possibility or the great possibility that we having lupus nephritis. If not, from the beginning, we diagnosed the patient have clinically to have systemic lupus erythematosus. Actually, the diagnosis of systemic lupus erythematosus, it is dependent on a certain clinical and laboratory and immunological criteria. But what is important in this aspect of diagnosis is that we might diagnose the systemic lupus through the kidney, through the pathological examination of the renal biopsy, as seen in this SLIC criteria in the year 2012 and still going till now. We may diagnose the patient to have systemic lupus if we find biopsy-proven lupus nephritis, including some of the abnormalities I just described in the previous slide, together with the presence of either positive ANA or anti-DNA. So in this scenario, we may diagnose systemic lupus through looking to the pathology in the kidney, but in the presence of either a positive serology for ANA and double-stranded DNA, because sometimes we meet patients in which the full criteria 4 out of 11 according to the American College Rheumatology, or 4 out of 17 according to this SLIC criteria, we cannot find these 4. But if the pathologist helped us to show some finding very characteristic to lupus nephritis, as I just described in the previous slide, together with the presence of either ANA or double-stranded DNA, we are diagnosing at the same time systemic lupus, the systemic disease, as well as the lupus nephritis. Also, the latest guideline for diagnosis of systemic lupus, it is called the EULAR and the ACR combined criteria, published in the year 2019. We have to diagnose systemic lupus if we have an entry criterion showing a positive ANA at a titer of at least 1/80, and again looking to the pathology. If we have a pathology showing class 3 or class 4, together with this only criteria of ANA positive, we have what is called a 10-weight score. 10-weight score is sufficient to diagnose systemic lupus erythematosus. So as we see, if we have a patient is not following several criteria of systemic lupus, we may diagnose him as having systemic lupus through looking into the pathology of the kidney. Regarding the prognosis, in the world of pathology, maybe since 15 years now, we have 2 important prognostic scores became available. The first one of them is burden classification prognostic score for ANCA-associated vasculitis. If we find more than 50% global sclerotic glomeruli, it is called the sclerotic class. If we find more than 50 normal glomeruli in a patient with ANCA-associated vasculitis, it is called the focal class. If it is more than 50% cellular crescent, it is crescentic class. If we didn't find the criteria sufficient to diagnose either of these, we consider this as a mixed class. And according to this figure, the best in terms of prognosis is focal, and as we may expect, the worst regarding the outcome is the sclerotic class. So it is a very important classification with important implication about the prognosis. The other one is the Oxford classification of IgA nephritis, also published at first in the year 2010, including these 4 criteria: the mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, and interstitial fibrosis. And every one of them is given a certain score according to the percentage of involvement. But later on, after maybe 4 years, it become updated and added another histological variant, which is the presence of crescents. Again, this is very important classification prognostic score for IgA nephritis. As given in this statement by Professor Daniel Catran from Canada, the median decline in estimated GFR in general in patients with IgA nephritis is 3.5 milli per minute per year, ranging in this from 0.7 if the patient have this score according to the Oxford score. But look, if the T score, instead of being T0, it became T2, it will result in much decline in the GFR, reaching to 11 milli per year. It means much decline. So it is very important, these two scores. I just giving a flash of light about them because of time limitation. The updated Oxford score for IgA nephritis and the Binding score for ANCA vasculitis. Also, it is important clinical implication from the pathology to give us idea about the disease progression in several clinical scenarios, including particularly patients with lupus nephritis, because patients with a certain class of lupus nephritis from 1 to 6 may be liable to either progression or regression, which is less common than the progression. So if we have a patient diagnosed, for example, to have class 2 of lupus nephritis, but upon following this patient, we find the patient is deteriorating in clinical terms of hematuria, proteinuria, and declining kidney function test. The patient may need another repeat biopsy. It will show us, among other possible diagnoses, that the disease may progress. Instead of being at one time class 2, became now class 4, which is the most bad class of the classes of lupus nephritis. Another important thing also for lupus is guiding therapy. All the nephrologists know very well that we diagnose at first systemic lupus clinically, and also diagnose lupus nephritis clinically by the presence of proteinuria and or hematuria. But the renal biopsy is the most important thing to guide therapy. In many scenarios, there is poor clinical pathological correlation. So I have to know at first which class of lupus nephritis, and according to this, I am going to guide therapy. These are the 5 classes, the 6th class of lupus nephritis. Actually, it is end-stage renal disease, including 90% global sclerosis of the glomeruli. But these are the 5 classes of lupus nephritis. If I received a pathology diagnosis from the pathologist speaking about this is class 1, I will add nothing immunosuppressive therapy. Class 2, according to the level of proteinuria. If we have class 3 or 4, it is called proliferative lupus nephritis. The patient suspected or expected to receive induction and maintenance therapy. If we have class 5, we have to ask ourselves at first if it is a mixed, I mean class 5 plus 3 or class 5 plus 4. So the treatment will be like the proliferative glomerulonephritis. If it is a pure class 5, whether the patient has nephrotic syndrome or subnephrotic edema, so the class of diagnosis will guide us towards the proper therapy for these patients. All patients receive this anti-malarial immunomodulating drug, hydroxychloroquine. The important last item for this clinical implication is the response to treatment. Again, speaking about our patients with lupus nephritis, if he is receiving or if she is receiving the standard therapy, and after a while we didn't find any improvement in the clinical response, we may repeat the kidney biopsy again to see if there are still activity score high, which may justify the use of more aggressive therapy like rituximab, IVIG, etc. Or on the other way around, we may find another diagnosis, for example, added antiphospholipid therapy that may need another treatment anticoagulant, or the patient may be already passed into class 6. At this time, we have to hold this aggressive immunosuppressive therapy, so it has a very clinical implication. The last few slides in my lecture, I will speak about the role of the pathology or the clinical implication of pathology in the renal allograft or renal transplant. There are 3 types of GN encountered in patients with renal allograft. The first one is the recurrent GN. It means that the form that affected the native kidney recurs in the transplanted kidney. Or new onset or de novo glomerulonephritis, in which occurs in the transplanted kidney whose original disease is non-glomerular or with a different pattern. And lastly, a transplant glomerulopathy, which means in pathological terms reduplication or multi-layering of the glomerular basement membrane or of the peritubular capillary in cases of multi-layering. And actually, it is a sort of antibody-mediated injury to the kidney, and usually entails that the outcome of this allograft is not good. Sometimes the patient presenting to us, we have no previous diagnosis of his underlying kidney disease because the kidneys are shrunken in size, and we didn't know what is the underlying cause, whether it is glomerular or non-glomerular. If this patient developed later on in the renal allograft GN, we cannot tell in a precise term whether it is recurrent or de novo. And in this scenario, we tell that the patient has post-transplantation GN. Another rare type of GN may be encountered also in the renal allograft. It may be transmitted in the donor kidney. In a very rare scenario, the recorded cases in which the donor having a very mild IgA or lupus nephritis, not diagnosed, and it is developing in the allograft later on. It is called donor GN, but this is a very unusual scenario. This pathology depicts here the finding of this TG or transplant glomerulopathy or post-transplant TG, where there is double contour in the light microscope and giving this lobular pattern together with the multi-lamellation and the double contour, as well as the positive C4D in the peritubular capillaries. All of these patients are usually presenting to us with proteinuria. And these 2 types of GN present in the renal allograft, together with CNI nephrotoxicity, are the most important causes of post-transplant proteinuria. It is very important to know the underlying type of GN, because if we have, for example, this recurrent GN, we may predict what is going on in the future or the rate of graft loss in the coming 5 to 10 years. For example, if we are speaking about type 2 MPGN, which is now C3 glomerulonephritis, it may predict that the rate of graft loss may be very high, from 34 to 66%, etc. So it will have a very important clinical implication for our patient to know the type of glomerulonephritis to predict what is going on in the coming 5 to 10 years. I think I have to stop at this time, and I thank you very much for your listening.
So thank you both for a very nice talk. The first one more technical, the second one more clinical. Thank you for having taken us around in this very fascinating journey. And I would like to ask you some of the questions, even if some of them were already answered in the chat, but I think that a few of them may probably be expanded a little bit. One is about the past, one is about the future, and one is about the present. The one about the past, in a way, it's not really the past, it's the present for many of us. You mainly showed, and I think this is very important to show that optic microscopy, light microscopy is the basis of everything. But if you should pick up a few situations in which electronic microscopy would be fundamental, what would you choose? And linked to these, since not everybody has an easy availability of electron microscopy and sometimes even of fluorescence, which advice would you give for stocking kidney samples to be able to share them in a second time? Who would like to answer first?
I can answer. Yeah, it's definitely the reality in a lot of countries in Africa where people don't have access to electron microscope. Definitely, that's an issue. I think not having an electron microscope. I think that in most cases, electron microscopy is done routinely when it doesn't really need to be done. I think in areas where it's essential are if you're dealing with a process which is very early on and not really coming up on your immunostains. So we use immunoperoxidase, and often if we have something like, say, a very early membranous nephropathy, we may not see the spikes on silver, and we may not get a very strong antibody signal on the immunoperoxidase. Also, if you've had a patient who's had some sort of bridging therapy before the biopsy, and there's maybe been some sort of partial treatment or partial remission, that can also be quite tricky to tease apart. Where for immunoperoxidase, again, we may not see much in terms of an antibody staining pattern, but we will definitely see the electron dense deposits on electron microscopy. We sometimes use EM a lot for podocytopathies, especially if we want to try and tease out primary versus secondary FSGS. We can sometimes look at the foot process diameter and try and make a case for that. But if you don't have an electron microscope, if you have a very good 100 times objective with oil immersion, you can see a lot of structure on light microscopy that you normally wouldn't see, which can really help you with the diagnosis. If you don't have immunofluorescence or immunoperoxidase, that's very tricky. You're going to have to just try and make a case for an immune mediated process by looking at the serology and complement levels. It would be very tricky, I think.
Yeah, and what about familiar nephropathies? Don't you think it's also a particular indication?
Sure. I mean, it wouldn't be enough to justify an electron microscope being in a department, but familial nephropathies definitely. Alport syndrome, Fabry's disease, and GBMs, any kind of like, especially the diseases which cause perturbations of the GBM, definitely, absolutely essential for that. But in those cases where are suspecting it, if you've got a good genetic history or family history where something is making you suspect a familial type of nephropathy, then that would ideally, be able to send that off to a regional center for EM. But those cases
you
would
have a
be
regional
quite rare.
center,
Yeah.
because you were saying, let me just say something, that it's not just Africa. I live in France. In France, there are only 3 centers that do electron microscopy. So it's really also cultural. It's really an important cultural gap that is not just an economic one.
Right.
So how would you suggest stocking some material for being able to do electron microscopy, for example, in a second time?
So, well, the best thing would be to firstly make sure that the clinicians, well, you could do it 2 ways. I mean, you could use formalin fixed paraffin embedded tissue and just wax it, which we sometimes do, but that unfortunately can sometimes result in a lot of structural changes to the GBM and podocytes, which can make interpretation quite difficult. Alternatively, the best thing would be to get a separate sample for glutaraldehyde fixation, and if you don't have access to an electron microscope, at least just put the tissue into glutaraldehyde. That can almost be kept there indefinitely, because the alternative then is that you would have to process it for resin embedding. And resin embedding, requires a lot of, expensive equipment and specialized knowledge. So you could keep the specimens in glutaraldehyde and then at some point in time use it. But the best thing would be to put it into resin.
Thank you.
Thank you.
And may I ask, I have a question. As I said, I have one for the future, very quick, for closing. So someone asked about AI, which is very trendy, and the answer was very nice. There have been many publications, but do you think, both of you, do you think it's the future, or do you think we have to wait for a longer period to use it better?
Maybe if no one else wants to go before me, maybe I can also just chip in here, because AI it's a field of interest of mine in pathology in general. And the problem with AI is that a lot of the models that are trained don't work well in samples that are from different institutions. So the big problem with AI is that the models that are trained are usually trained on certain scanners, and certain laboratories have different ways of staining. Like in France, they use saffron for the H&E staining, which is not being used anywhere else in the world. And each laboratory has a different kind of slightly different method and recipe for H&E or PAS staining, which at the moment is limiting models that are trained in, say, Europe to be used in, say, samples from our laboratory. And it's also very labor intensive. You have to have pathologists who are going to be able to label each glomerulus as being normal or globally sclerosed or segmentally sclerosed, someone who's going to have to draw out interstitial fibrosis and tubular atrophy. But the rate of things are going at the moment, there's a big push for what they call unsupervised AI, where if you have enough samples, the machines can kind of work it out for themselves. But the problem is getting enough samples and having enough computing power to do that. And so at the moment, it's very limited. Your AI can work for very specific tasks. So being able to distinguish a normal from a sclerosed glomerulus, or maybe mild from severe IFTA. But in order for it to be like one program that's going to be able to spit out the entire report automatically, I think we're still a couple of years away from that. But the field is developing very rapidly, and things that were thought not to be possible a couple of years ago when I first got involved with it are now being identified. I mean, they've now developed a program called PathChat, where you can actually just upload any slide of any histological image, and it will tell you exactly what it is. The machines can actually identify exactly what it is, and that's the way it's going to be going. I think we need to, and it's going to be a fantastic resource, because it's going to address the shortage of nephropathologists, and I think it will be able to also help with our workload, because I'm a general pathologist. I have other kind of things to do during the day, not just renal pathology, unfortunately. I think it's going to get there. But the big problem is being able to translate a model that's been trained on samples in one laboratory to work on samples that are scanned on a different machine in another laboratory.
So thank you so much for this, for giving us a rendezvous in 2 years to speak about artificial intelligence in this context.
Sure.
And thank you for having invited me to participate to this fascinating trip in nephropathology, short trip in nephropathology. Amir, would you like to close?
Thank you so much, Professor Georgina. Thank you so much, Dr. Brandon, Professor Isam, and Professor Nikki. This has been very informative and thoughtful webinar. I think we learned a lot today, and we learned also that we need to do more and more of these nephropathology webinars in the future. We have very good expertise in the field, and we should, I think, take advantage on that and learn more and more. Nikki?
Yeah, no, I agree with you. I think the talks today were really exceptional and very, very informative, and a great learning experience. And I agree. I think we need to allocate a little bit more time next time. And I think it was fantastic. Yeah.
Thank you so much. And we'll see you in the next webinars. We'll try to do at least a couple of nephropathology webinar in the next 6 months. Have a good afternoon, good night, and maybe good morning for everyone.
Bye-bye. Thank
Good
you.
morning.
Bye.